Now I'd like invite Dr. Pratima. She's a developmental pediatrician at Rainbow Children's Hospital. Ma'am has a wide experience of 20 years. She worked with NHS for 10 years and in Australia and New Zealand for the rest of the years. She's a consultant developmental pediatrician. She is even involved with training developmental pediatricians. She did a lot of research and she is one of the primary investigator in a research related to gut microbiome with respect to autism spectrum disorder children. She is trained in ADOS, it's a gold standard testing for autism, and also the general movements for cerebral palsy, and she also certified in the Bailey scales. She is one of the Cochrane author in ketogenic diet and epilepsy. And I would like to invite Ma'am on the stage. She will be covering us the topic on evidence-based intervention strategies. Now, as professionals, we all talk about evidence and evidence. So, Ma'am would be giving a light on one of such strategies named Early Start de Nouveau model.
Thank you for this opportunity to share some information about this intervention strategy. As Joshna had sort of mentioned, I have been abroad for 20 years and I've come back quite recently. I'm only 2 months practicing in India and part of Team Rainbow. What I've experienced very briefly in the last 2 months has been just a very staggering increase or number of children with autism. While I've been abroad in Australia, UK and New Zealand, there have been very high number of children with autism. In fact, some of the general pediatric clinics were actually filling up with children with the referrals of autism. After coming here, I was expecting that I would be very slow to pick up my practice, but I've had almost 180 children in 2 months' time. It's just very staggering, and I'm seeing a theme that you have covered, Sana, and about isolation, about both parents working, moving away from their native places, losing the support. We don't know what is happening there, but definitely the theme is very, very similar. So we definitely need to sort of research that to kind of attribute causation to that, but very, very sort of worrying thing going on around us. The other thing was that the high number of sort of centers in Hyderabad, I was pleasantly surprised to know that we have, did Dr. Somashekar mention about 400 centers or so in, which is, I mean, we need those therapy centers. Just given this high increase in autism, as professionals who deal with children on the spectrum, I think we need to do our very best to bring the best evidence-based practice to support these children, to offer them the best chances that they have. So I am not an interventionist, I'm a developmental pediatrician, but I just wanted to dip a little bit into the Early Start Denver model. I don't know if any of you have trained in this model, in which case you can correct me on that. We will go briefly through this as a way of just familiarizing ourselves with one of these strategies. I wanted to acknowledge right at the outset the developers of this and the authors of this model. There are actually Dr. Sally Rogers, who is a psychiatrist in UC Davis, University of California, Davis, and Dr. Jerry Dawson, professor of psychiatry at Duke University. What I wanted to mention is that it's not a short, there is a great history behind this model. It started from that original Denver model, and it has taken about 2.5 decades of research. And what have they looked in that research? They've actually looked at developing intervention models. They have studied these children, and they've looked at the neuropsychological profile of children in early autism to see what exactly is happening in the brains of these children. So I just wanted to sort of mention this disclaimer that a lot of the information that I have taken is from the course that I have done on the Early Start Denver model, as well as this manual on the ESDM. So this is the roadmap of what I will talk about the background, the ESDM, a little bit about how children with autism learn, overview of the foundational principles, a few things about the practice, and then some reflections. So as has been mentioned by our previous sort of speakers, this is rising. And I think from the 1 in 54 figure of last year, we've actually moved to 1 in 44 this year, released in January by the CDC. I was looking at studies in India, and there are a few prevalence studies. There was this one from 2017, which looked at 5 regions, and in each region it covered about 25 villages and towns, etc. And they've put the estimate as 1 in 100 for autism and 1 in 8 for neurodevelopmental disorders, which is still very high. So, I mean, clearly there is a need for trained professionals to look after this cohort of children. Now, what is the problem of ASD? We are embracing this model of neurodiversity, and we know the high-functioning ASD people. We want our society to be more embracing of this neurodiversity. But, like Sana has mentioned, about 30 to 40% of them will have significant developmental intellectual issues. And this is a huge burden. I had a little child last week, 5 years old, high functioning, and then the mother came in tears to tell me that the school has said to the mother that your child is abnormal, and the girl said they are saying I'm a pichi dana, very, very hurt. A very inclusive school, but the initial sort of responses and the bias we have towards some of our children is still deeply ingrained, and much work needs to be done. So even if they are intelligent and high functioning, there is discrimination. They have difficulties with isolation. There is an awkwardness. There are ongoing employment challenges. I have some close relatives who struggle with getting themselves employed. The employers call them unemployable, and that's a huge difficulty. And so you can see that entire burden that autism can sort of cast on the society. This is the diagnostic criteria as per the DSM-5, and for the last sort of 12 years, I have used DSM-4 previously and then moved to DSM-5. It is a very I find it's a very easy sort of diagnostic criteria to use. You have 2 domains, the social communication and the rigid, repetitive, restrictive sensory behaviors, which is actually, if you systematically go and assess a child's behavior as per this criteria, I find this is very, very helpful both to the parents and clear to us about assessment of these children. You can pick up the strengths and you can pick up the difficulties of these children. So moving on to intervention, there are many parents who come with, my child needs speech therapy, but there are a number of parents who are now quite aware, and they know that there are many other components in therapy. It's not merely speech therapy. So just to sort of emphasize that our children with autism require strategies to support their learning, their communication, and a big part of the communication is the pre-verbal skills. They require support with sensory integration, socialization, and behavior. So there comes our whole multidisciplinary team of therapists, and each child will be unique, and each one will have their own needs. I wanted to just project this meta-analysis that came out 2019-2020, looking at a comparative sort of evidence between the different approaches. So it looked at behavior approaches, which is your ABA, any psychologists in the group, then developmental approaches, then the combined developmental and behavioral approaches, sensory integration, teach, animal, and technology assisted. So it looked at a fair bit of data, And what this came out to say is that the developmental and the combined developmental behavioral have got the best evidence in terms of improved outcomes in children. So what is a combined developmental behavioral approach? So it integrates a behavioral approach, which is your the antecedent behavior consequence, and the developmental one, where the child is the one who is exploring the environment, seeking and learning. So one example of this developmental and behavioral is the Early Start Denver model, along with Hannon as well. So this program recommends that children should have intensive therapy of almost 24 hours at least per week, which translates to about 4 hours per day, and preferably even more. So just by the short form for Early Start is ESDM, and so it's a very comprehensive early intervention that combines the developmental and behavior approach. It is for toddlers with autism, starting at 12 up to 36, and you can take it up to 4 to 5 years. And it's not suitable for children beyond 5 years. The goal of ESDM, so initially there was a lot of emphasis on curing autism, and unfortunately those early studies have been quite disappointing, and so the focus has now shifted to the goalposts are different now. It's about reducing the severity of symptoms of autism. The rigid repetitive behaviors can be very problematic for some children. If they're stimming a lot, it'll take the focus away from children being able to sit and learn. So what ESDM can do is reduce the severity, it can accelerate development, then it can reduce the problem behaviors, and it helps the children cope better with their daily expectations. In other words, help with their adaptive skills. So this is the focus of ESDM. What exactly is ESDM based on? So it might be good to just dip into a little bit of the background to know how children with autism, how children learn and how children with autism learn. So research has kind of shown a lot of light on how infants learn. We've actually moved on from the Piaget's constructivist theory, where children go exploring and learning, to children being active learners. They've also been called statistical learners. They're taking in the data of their environment and kind of responding to that. And now there is another component, that unless children and the environments effectively engage with each other, so at an emotional level, the learning may not progress. So that affect is a very important component of ESDM. Children can start to recognize faces and discriminate their mother's face and all that in that 3 to 6 month period. So it's quite early on. And I just want you to pause and think, instead of seeing the mother's face, if we have put our kids in front of screens, you're watching Peppa Pig, or which is quite a favorite with our kids, and those figures, can you imagine how different it would be for these children? They also start to interpret behavior. So babies looking at moving bodies versus watching screens and the information coming in through the digital media. So all this learning, quite a lot of learning happens in that first year, particularly first 6 months. So ESDM uses this knowledge of typical baby development. That's the first point. The second point is about how autism impacts brain development. So infants who are starting to show signs of autism start to spend less and less time looking at people. And this starts manifesting very, very early. They won't respond to name. They fail to develop gestures, which are important for language development. So early symptoms of autism actually suggest that that's a system of the brain that supports language development, which is your temporal lobe, the amygdala, and the prefrontal cortex. All that is impacted, that's affected. There's also sort of evidence to show, that there are studies about large head sizes There is differences with cerebellum. There is a difference in the social brain network functioning, and also the mirror neurons. This mirror neuron is actually a very important component of our brain. This is the one that helps us imitate. And we're going to come to this. The imitation is one of the things in autism that is affected. And then the third important point on which the ESDM is based is on brain plasticity. So even if children have suffered injury to the brain, they will still learn because of plasticity. And this feature is kind of used in ESDM, that if we teach our children, especially in that first 2 years, you are going to have good outcomes. And there is evidence that experience can shape brain function, and this becomes the premise of early intervention and in shaping brain development. So this was about how infants learn. I just wanted to take you through some of these other approaches which are actually part of ESDM. They were all originally independent models for autism, understanding of autism, but all that has been integrated in ESDM. So I won't delve deep into the theory, but I'll just pick up a key point from each. So in the Denver model, it basically says that these children fail to develop social communication development. What ESDM does, it focuses on building close relationship. So between the therapist and the child, between the caregiver and the child, the focus is relationship. That is a very key thing in this model. The second one is the Rogers-Pennington's model, which says that autism has got an early impairment of imitation. Just think about it, and if you think back to all the kids you have seen with autism, imitation is less. In the high functioning, you might see some imitation, but by and large, imitation is a quality that comes late. They find it hard to imitate. So this ESDM again focuses on developing this. And how does it do that? It does by providing a very rich, emotionally rich relationship by responsive caregivers. It wants the caregivers to respond with exaggerated affect. There is this social motivation hypothesis that children intrinsically within their brains don't have a motivation to socialize because they don't care much for that reward of socializing. So again, what is built in ESDM is what is called the sensory social routines. Basically, which means there are two partners, a dyad, and the focus for each other is the other person, not the object. So then the infant or the toddler will be, compelled to look at the face rather than, the toys or the objects. So that's the third one. And the fourth one is the pivotal response. Again, for psychologists in the group, it's about improving motivation and thus improving behaviors. So just putting it in simple words, ESDM recognizes that there is a problem with this initiative, social initiative in the children. So it addresses the interaction by fostering initiative. It follows each child's interests. So there is this respect for the child's interests, and it provides a scaffold then to help the child communicate and interact. It provides coordinated interactive social relationships for much of the waking time, and this is how it improves the number of episodes of social interaction for that child, assuming that there has been a big deficit of that. So the social experience for the child can occur. And then it is an intensive model because there is the understanding that it has to fill in for this deficit of social interaction for this child. And it seeks to empower children with ASD to become active participants. These are some of for the interventionists in the group. The ESDM looks at these treatment principles. Like I said, affect is very important. You have to show enjoyment with the children and show that sort of demonstrate that in our interaction with the children. And it seeks to enhance the reward value. So we are working hard at all these skills. There is a shared enjoyment, and parents are an important component of this. Parents are involved. We don't need any special materials for this. Real life stuff can be used. there is a big emphasis on all the pre-verbal skills. So gestures, joint attention, imitation, all these are emphasized. So and then non-verbal and verbal communication. It doesn't just focus on one area. It focuses on all areas of the development. So play, cognition, motor, sensory, etc. And play is an important component. Then it's based on very sound learning theories. It is not one discipline, it's multidisciplinary disciplinary approach, and then it's individualized for each child. So this is the sort of the treatment principles. Then in practicality, what exactly is involved? So ESDM has got a curriculum and some procedures. So that's the book I was talking about, which promotes language learning engagement, and there is a checklist. So just very briefly, the checklist sort of is, so it has got these items which are developmentally sequenced, and it is organized into 4 levels, level 1, 2, 3, 4. These actually are based on research of children with autism, where the trajectory of language is much slower compared to the motor development. So that is assessed in the child, and you mark it. So you get a series of passes, and then you hit the series of fails. That is your zone of targeting, the zone of proximal development that the therapist will have to target. So very important is play, imitation, nonverbal communication, and the current skills of the child are evaluated, and then you write down the objectives. So in ESDM, you do this for a 12-week period. You look at what objectives can be achieved within 3 months or 12 weeks, and you kind of choose those objectives. And then at the end of the 12 weeks, you review that again. So in the teaching procedures, one part is formulating objectives, and then you analyze the tasks, the steps. You've got the notebook and the daily data sheets. It's embedded in play activities. So it's not our conventional therapy model. It is embedded in play. It addresses, you won't do one skill at a time. You will do multiple domains that you will just cross-cover. And this occurs at a very high rate. So once again, it merges the Denver ABA and PRT. Positive effect is very important. Play is a big frame for teaching. Teaching becomes very intensive, and family involvement. A few things about the practicalities. In terms of setting, you can do it at home or you can do it in the clinic. It looks at children between 12 and 60 months. It is given by trained interventionists. It can also be done as a group session. And it can be targeted to parents. It can be with the therapist and the child as well. There is this generalist model. So even though you have a multidisciplinary team, one therapist will have to take the lead and connect with the family, so as not to overwhelm a family with too many people, and then working alongside and supporting the family. A few words about developing objectives. I spoke about the zone of that proximal development, so that skills that you are choosing have to be thought through. They have to be constructed, keeping in child the mind and what is most functional. Rather than just going down the list, you choose what will help this child improve the adaptive skills. Now, for example, this is American English, but I'm sure when we do it in India, we can modify this as per our use. But they say during a song, so for this child called Tanvi, you would set it up like this, very explicit objective. So when an adult offers a routine or stops a routine, she will use eye contact and gesture to request 5 different routines. Now, Sana, you have said you worked very hard to develop attention or joint attention. So this can take months to achieve in children. And so we'll have to break it down into 5 or 6 steps and then monitor this on a daily or a regular basis. Again, the same points I've emphasized. And just looking at evidence, but when this model came out in 2010, or it was published, there were about 8 database outcome papers, including in RCT. 2 years back, it has been replicated in about 20 studies, and so there is a huge body of evidence. This is the website, and this course can be accessed online, the introductory. It's about $400 American. And finally, my reflections. Now, we've got a huge burden of autism spectrum. We need robust intervention techniques and approaches, and I think it's our responsibility to offer to our children the best we can. And ESDM kind of fits the bill, being a blended developmental behavioral approach. It's comprehensive. It occurs in natural learning environments. It's manualized and it's quite easy to follow, and it's evidence-based. So thank you.
Thank you, Dr. Pratima. That was an excellent presentation. So we have taken us through patient implementation of future for amazing purpose. We're very happy and how much we have to stand up. And such kind of models will definitely help us start learning on now. So we can see a better picture of the children. Any questions from the audience, please?
By the way, my name is Shravan Kumar Reddy. I am from Child Development Center, Madhapur. So I would like to request the referral team. The missing link here, like in our culture, we are a little new. In our culture, when the referral source has been referred for particular therapy, parents' attitude that 2 things. 1, I'll pay, you work. Or child won't listen to us. Or what do you say? Some of them they don't have time, or sometimes professionals are not ready to teach something to the parents population. So recommendations, whatever the recommendations by the doctors or the psychiatrists, psychologists, whoever are referring, topmost should be parent involvement. Whatever the word you put it, parent also has to be learned. That has to be there. Then only they will feel. Otherwise, I mean, of course, they are also new to the when they was in a diagnosis, they are into lot of emotional trauma. So if that comes, that will help them to understand. Okay, it's not only the professional job. We should also learn and involve. Then only whatever the topic we have discussed is meaningful. So if I say you sit and learn, then they say I am paying, you are working. Why should I learn? If a referral source says that along with the therapist you also learn and implement, there the mindset will be very good. That's that one thing I should highlight today. Thank you. Yeah.
We see parents at a different stage in their journey. Some of them have understood and they know their own importance in this journey, and they will be very switched on to participate in the intervention. Then there are some who probably have still not understood the whole reality of the situation, and you may have experienced some parents who think that, okay, now that's your job, you do it, and look after the child for 2 to 3 hours. But autism is a very long journey, and our role as therapists will be continually to be patient, to hold the hands, and just continue to be, compassionate. At my end, I'll do my very best to educate about expectations from a therapy center, so that their expectations are realistic and they know exactly what to do, and emphasize their role, because that is important. Parents have to participate in this. They are the big part of the environment of the child, and unless we address that, we are not going to influence our child. Half an hour, 1 hour, or even 2 hours of therapy won't be enough. We need parents to be a partner in this. So, but definitely I take your message on board, and we'll make it very explicit and clear.
With a therapist, okay, it's 1 hour in the room, but the actual learning happens outside the room. And the parents have to be told that this is empowering them to help their child. I think when we educate them enough, they will definitely cooperate.
uh, 0.5. Currently, he is getting help from the therapist from Let's Habitat Therapy Center, LB Nagar. So, what I want to add to the point which Sir mentioned is definitely correct in one way, that first 2-3 months is very traumatic as a parent to see your child different from the other kids. But what I'm saying is, what he mentioned is an important point, that the root level, whenever we are diagnosed with this, when the therapist, when the psychiatrist or when the evaluation says us that you also need to get involved, definitely it will go into the heads. But since we are in a trauma, that first of all we cannot diagnose, and we'll be in a hurry how to make him normal, rather than understanding that it's a personality. We always will be in a hurry that how can we come out of that tag called as autism and place him into a normal school. So what I feel is every therapy center itself also should take the initiative, because most of the, unfortunately, this is becoming a very commercial industry, because there is no reference. This is a new world to us. For example, if you get a heart disease, normally we go to another heart specialist and take a second opinion of how easy, if the first doctor is suggesting an operation, do you think we can go, we have to go it, or there is any medical evaluation we can do for it, we should go for it or not. But autism itself is new to India so much, and therapy centers are coming like every one for one street. So it's hard to understand whether they are doing it like Sir said. When they ask to do, we'll always be in a dilemma. Is he being very commercial about it, or really we need to work about it? So what I think is, to add to Sir's point, we need therapy centers. For example, the therapy center, I am not advocating about any therapy center, but we, Let's Habitat, we parents, we organize like a group therapy every Saturday, and we sit, and our ma'am will give us knowledge on how, and it's like not like, it's just not like telling us in a sweet way, it's always in a harsh way. Are you working? I want videos that you are working, and I will force feed you with information. You have to know what your kid is going through. We just do only 40 minutes of therapy, and you parents have to work at least 2 hours. It's your responsibility to work. So she gave us a lot of knowledge. So what I want to say to Sir is, thank you Sir for raising up this point. This point has been the major point for every parent. As therapists, if you also little bit force us and say that and give us knowledge, not every parent but most of the parents would try to involve, and we also don't have knowledge, no Sir. So if you involve us, we'll also, not every parent is like that we'll pay and you have to do. With our lack of knowledge, we try to do it, Sir. So please educate us, that's it. We'll do it. Thank you.
Very nice input from the parents. So, to summarize, the points to remember is, there's always look at the evidence and the strategies you need to learn as a parent, as a professional, in order to facilitate overall development of the child. So Deliver model is one such evidence-based practice which gives most importance on the connection between the child and the caregiver, or the connection between the child and the environment. The rest all follows with it, whether it's a verbal communication or the non-verbal communication is just a mode of communication which shows the connection between the child and the environment. Thank you so much, ma'am, for your comprehensive presentation. Now I request Hari ma'am to facilitate Dr. Pratima Giri. As and when you get a time, please try to understand the evidence and try to read on at least the basics of Deliver model. It's really a nice and valuable information which we all need to take home. Thank you, ma'am.